Hi, good day and good evening, everyone. It's nice to see you all here. Please let me know if you can hear me well and if everything is working fine, so we can start. If I can have the feedback from you. I'm Sophie, and I will be your host today. Welcome to IVF webinars by Egg Donation Friends. We are meeting here for some time now, and we are actually here every week. All IVF webinars are available on our website. We have a vast source of knowledge, so if you already know that, it's good for you. If you are here with us for the first time, I can only encourage you to dig into it or just share it with anybody else. IVF webinars are done with the help of our partners, and our partners are Spende, fertility clinics abroad, and Donor Conception Network. And today we are here to talk about PGS and PGT-A, actually, genetic embryo screening. Is it really worth it? And let me welcome our guest speaker, medical director at GENNET City Fertility, Dr. Benjamin Abramov. Before Dr. Benjamin Abramov will take over, I will just remind you that the webinar is being recorded and it will be available on our website tomorrow. And I think this is all from me for now. So, Dr. Abramov, are you ready?
I'm ready, thank you. Good evening to everyone here in London. If you are elsewhere in the world, then good day to you. Welcome to this seminar. We'll spend about 40-50 minutes speaking about PGS, which is the acronym for Pre-Implantation Genetic Screening. It's also known by the name of PGT-A. I will elaborate about it later too. But before we speak about PGS, we should perhaps spend a few minutes just talking about standard routine IVF treatment. This slide is a schematic diagram of what IVF involves. So if you follow my arrow on the screen, the first stage of IVF treatment is ovarian stimulation. It is aimed at causing you to mature more than just the one egg you mature in a natural cycle anyway. We aim normally at 10 to 15, perhaps 20 eggs in PGS cycles. The second phase of IVF treatment is egg collection, which is represented here by a syringe and a needle. It's not done by a syringe, it's done with some higher technology, but the principle is the same. In theaters, we aspirate the fluid from the follicles in your ovaries, and the fluid is given to a scientist, an embryologist, who separate the egg from the fluid, puts it in a dish, and mixes the eggs with sperm to fertilize the egg. And then stages 4 and 5 are essentially embryo culture. We grow the embryos in the lab for a period of anything between 2 to 5 days. I will elaborate on it later. And then we select an embryo or 2 and sometimes 3, and we put them back inside the womb so that they can implant and end up with conception. This slide shows you how a stimulated ovary looks in reality when we scan you. This is the ovary. Every black circle is a follicle. Every follicle should contain an egg. We don't normally get 100% egg yield. Not all follicles release their eggs, but we get something normally close to that figure. This is how the eggs look in the dish, in the lab. The egg comes with a fluffy layer of cells around it. So this is the egg, and this is the fluffy layer of cells around it. And the fluffy layer of cells called cumulus cells, they have a role in nourishing the egg when it grows in the follicle. They also have a role in blocking polyspermic fertilization. They make sure that the egg is not fertilized by more than one sperm. As I told you, in standard IVF, we incubate the egg with lots of sperm in a ratio of, in our lab, it's 10,000 motile sperm per one egg. In other labs, the ratio can be even higher. The sperm swim until one sperm manages to make contact with the surface of the egg and penetrate into it. Once this happens, this fluffy layer of cells around the egg becomes more compact and traps any other cell en route into the egg to fertilize it, so that it's not fertilized with more than one egg, as I said. When the sperm profile is not that good, when the count is low, or when the motility, the percentage of sperm cells in movement is not really optimal, having just standard IVF, having just the eggs incubated with the sperm will not be enough, because fertilization will not happen. And what we do under such circumstances is to load an individual sperm cell onto a glass needle and inject it into the egg under the microscope. You will see it really very nicely here in a video that we will soon load. So what you see here is obviously magnified under the microscope. On the left-hand side, you see a pipette that uses a bit of suction to make sure that the egg does not move. This is now a denuded egg. It doesn't have the fluffy layer of cells around it. It only has its shell, what we call the zona pellucida. The sperm is there in the glass needle. This glass needle's diameter is 1/10 of a hair, of a human hair. The glass needle goes through the shell of the egg into the egg. It aspirates some of the content of the egg to make sure that you're actually inside. And then the content of the egg and the sperm right there are released inside the egg to fertilize it. And the needle is then removed, of course, and the egg is kept in the lab, and we wait to see if it fertilized or not. Fertilization check normally happens the day after, whether you fertilize by standard IVF or whether you fertilized by this procedure, by ICSI. A day after fertilization, you want to go back and check the egg to see if it fertilized or not. Sign of fertilization is the appearance of these two little bodies within the egg. These two little bodies, shown here schematically, are the pronuclei. Each body contains the genetic material of one partner. There's a female genetic material and there is male genetic material. An egg that shows you that it's got these two bodies fertilized normally. If it shows you only one body, or if it shows you two, if it shows you none, then it means that this egg did not fertilize. If the egg shows you 3 or 4 or 5 sometimes such bodies, it tells you that it fertilized abnormally, that it could be that more than just one sperm cell penetrated the egg and fertilized it. So this is what you expect to find a day after fertilization. You want to see that the egg has got 2 p.m. This is how we call it. You can put the fertilized egg back inside the womb at this stage and you will get pregnancies. The issue is that you normally have several such fertilized eggs, and choosing the right one to go back inside will be pretty much like tossing a coin. It will be an arbitrary decision. You cannot make any statement other than saying that this egg fertilized or did not fertilize about the quality of this fertilized egg. And this is why we normally keep the fertilized egg for another couple of days in our labs before we make that decision. On day 2 after fertilization, you will expect to find that this fertilized egg divided first to 2 cells and then to 4 cells. So when you come back on day 2 after fertilization to check the eggs, you wish to find that they have either 2 or 4 cells. And this is a very nice 4-cell embryo because the cells are even, they look pretty much the same, and there are no fragments or bits and pieces of cells around those 4 cells. So this is a good quality embryo. You can put it back in and you will get pregnancies, but as I said, it is very common that you will have several such embryos that look very similar, and it would be difficult for you to decide which one you should really put back inside. So we hardly do any day 2 embryo transfers nowadays. We normally wait until day 3. This is how the embryo will look on day 3 after fertilization. You expect to find 6 to 8 cells. And again, this is a very nice looking embryo. The cells are even, there is no fragmentation. You can put the embryo back on day 3 and you will get pregnancies. And indeed, very often, this is exactly what we do. If on day 3 after egg collection, after fertilization, you have 1 or 2 good-looking embryos and the rest are not as good-looking, you already have your selection. You already know which embryos you should put back, and you can perform the embryo transfer on day 3. However, very often, the choice as to which embryos you should put back on day 3 is still difficult because the embryos still look very, very similar. So what we normally do is raise the embryos for a bit longer. We wait until day 5. On day 5, the embryo is no longer just a clump of a few cells. It is already a structured embryo. A structured embryo called a blastocyst. What you see in these photos and with the illustration is pretty much like a disc. But in reality, obviously, this is not a disc. This is a 3-dimensional object. And what you want to imagine really is a golf ball. So imagine the cobblestone appearance that the golf ball has. The cobblestone appearance of the golf ball is what we call the trophoectoderm. The name doesn't matter, but what matters is that this layer of cells, the surface of that golf ball, is the layer that will become the placenta and the membranes. Inside this golf ball, you will find fluid. This is why we call it a blastocyst. And in that fluid, you will also find a clump of tight cells called the inner cell mass. You can see it more clearly here. You can see it here. The inner cell mass will become the actual embryo. This blastocyst will hatch from its shell at some point, which you can see here. It will first form a figure of 8 with a little bit of it herniating out, and then eventually it will hatch out of its shell completely before it implants. An embryo that manages to go from the first inspection of 2 pronuclei, when you see that it's fertilized, to this stage of a structured embryo tells you a lot about its ability to implant, and it will be your candidate to put back. If the patient is young, we normally put only 1 embryo back, one blastocyst back, because we are pretty certain that this blastocyst has got a very good chance of implantation, but the implantation rate is not 100%. If the patient is a bit older, we will put 2 backs to increase the chances that at least one of them implants. This video will show you all that we discussed in a clip through a time-lapse incubator. Time-lapse incubator is an incubator that takes images in certain time intervals, and then you can make a clip. So you saw the embryo at the 2 pronuclei. This is a day 2 stage when you have 4 cells. This is now a day 3 stage when you have 6 to 8 cells. And it will soon be a day 4 stage when it's a clump of very tight cells, and it will become a blastocyst. You now starting the blastulation, and this is a complete blastocyst with the trophoectoderm, the shell that will become the placenta and the membranes, and the inner cell mass, which will become the embryo itself. So this is 5 days of embryo development in a few seconds of a clip. Now, in IVF treatment without PGS, as I said, you will very often have a number of embryos that you manage to form, and you will need to make a decision about which embryo should go back inside. whether you do that decision, whether you make that decision on day 3 after fertilization, or on day 4, on day 5 when you already have blastocysts, the decision will be made on the basis of observational parameters. In other words, you will make a decision on the basis of how well does the embryo look under the microscope. Whether it is fragmented or not fragmented on day 3, whether the cells are even or not even on day 3. And if you wait until a blastocyst stage, there are other parameters that you use to decide whether the embryo looks good or doesn't look good. It's an observational basis to your decision. In IVF treatment with PGS, you make that decision on the basis of whether the embryo has got a normal makeup of chromosomes or not. And I will soon elaborate on that, and you will understand what I'm referring to. And the morphological grading comes second. So what you do first is you test the embryos to see if the embryos contain a normal complement of chromosomes. And after you've decided which embryos are genetically normal and which embryos are not genetically normal, you take the normally genetic embryos and you decide which one should go first according to how well they look under the microscope. So now, to just clarify a few terms that I have used here to make sure that we are we all sing from the same hymn sheet. So what is PGS, or in its other name, PGTA? PGS and PGTA refer to the exact same thing, the exact same technology. PGTA stands for Preimplantation genetic testing for aneuploidies. I will explain what aneuploidies are in just a moment. And PGS is an acronym for Preimplantation genetic screening. PGT-A is the newer nomenclature, but both PGS and PGT-A are used interchangeably and refer to the exact same thing. We will use the term PGS in this presentation because I believe that the majority of you are more used to this term than to PGT-A. So what are aneuploidies and what is euploidy? Aneuploidy refers to an incorrect number of chromosomes. If the embryo or a subject, a human being, has an addition of or a deletion of a whole chromosome or a part of a chromosome, then this subject or this embryo have aneuploidy. Euploidy is the correct and complete number of chromosomes with no deletions or additions of a whole chromosome or a chromosome part. What are chromosomes? Chromosomes are tiny packages of DNA. Our genetic material, our DNA, this giant molecule, is organized in our cells in little packages. In human body cells, you should expect 46 chromosomes in total. But the better way of describing it is to say that we have 23 pairs of chromosomes because we all receive one chromosome from our father, one chromosome from our mother, and we have a total of 23 chromosomes from our father, 23 chromosomes from our mother, and then this becomes 46 chromosomes in total. So the pairs of chromosomes consist of a copy which is of maternal origin and a copy which is of paternal origin. I think that this will become clearer as we move on with the presentation. This is, you can map the chromosome. You can take a blood test, or you can take cells from the inside your mouth and send them to a lab, and the lab will make a map of your chromosomes. And the map will show if you have a normal complement of chromosomes or if you have an abnormal complement of chromosomes. So this is a map of a normal female, what we call karyotype. the way we normally describe it is 46XX, because this female has got 46 chromosomes, and she has got a pair of the X chromosomes. These are the sex chromosomes. So if you look at the map, starting from chromosome 1, making your way through the other chromosomes up to chromosome 22, there is a pair of each chromosomes, and there is a pair of chromosome X. This is a normal female karyotype. This is a map of a normal male karyotype. So here, if you look at the map, you see that there is a pair of chromosomes, again, maternal and paternal, from each chromosome, starting from chromosome 1, making your way through the entire map to chromosome 22. But because this is a male karyotype, it has one copy of chromosome X and one copy of chromosome Y. This consists of a normal set of sex chromosomes for a man, or for male. So this is a normal karyotype for a boy or a male embryo. The best known or most famous aberration in the number of chromosomes is trisomy 21, or what we also call as Down syndrome. And what you have here is a chromosome map of a boy with Down syndrome. So if we look together at the map, we see that 1, 2, 3, 4, 5, all the chromosomes have got a pair of chromosomes, other than chromosome 21, in which there are 3 copies. The fact that there are 3 copies, the fact that there is an additional copy of chromosome 21, is what causes the host of difficulties that babies and adults with chromosome 21 are faced with. So there's a degree of mental retardation, and there are specific characteristics. These babies are more prone to having leukemia. They are very often born with some malformations, whether these are heart malformations or issues with the gut and so forth. The risk of conceiving with a baby that is affected with trisomy 21 is associated with advanced maternal age. The older women are when they are pregnant, the more likely they are to have a baby with Down syndrome. But what is perhaps important to mention is that babies born with Down syndrome are probably the tip of the iceberg of the occurrence of Down syndrome in embryos and in pregnancies. Because if you check the products of conception of women who conceived but sadly miscarried, you will very often find out that the embryo that they conceived with had Down syndrome. So Down syndrome can be a cause of miscarriages. Trisomy 18 is another difficulty that sometimes babies are born with. It's called also Edwards syndrome. And if you look at this map of a boy, it happens to be a boy, but it can happen in girls too. You will find that it has a right copy of chromosomes from chromosome 1 all the way to chromosome 22. It has the X and Y chromosome that make it a boy or make it a male. And if you look at chromosome 18, this is the only exception. Chromosome 18 has got 3 copies. Again, these babies are severely affected. They are more affected than babies with Down syndrome, and they normally do not make it to, and they don't really survive more than about 6 months after delivery. This is also a bit more common in women who are older when they conceive, and it is also a very common cause of miscarriages. Another example would be trisomy 13, which is called also Pateau syndrome. If you look at the map here, the karyotype here, you will notice immediately now after you've gone through the previous two examples that there are 3 copies of chromosome 13. Again, this baby will be severely affected, will not last for more than a few weeks after delivery. And again, trisomy 13 is very often found in miscarriages. It can be a cause of a miscarriage. It's not only additions of chromosomes that can cause problems. A deletion of a chromosome can cause problems too. This is a map or a karyotype of the chromosomes of a girl born with Turner syndrome. If you look at her karyotype, you will notice that she has a pair of each chromosome all the way up to chromosome 22, but she has only 1 copy of chromosome X instead of the 2 copies. So that second copy of chromosome X is missing here. These girls are born normally, they normally suffer with short stature. There are certain characteristics such as neck webbing, elbow deformities, etc. The possibly more important thing is that they very often have premature ovarian failure, or they have complete sterility. The ovaries are non-functional. The interesting thing about Turner syndrome, or 45X0, this is how we call it because she's missing 1 chromosome, chromosome X. She doesn't have 46 chromosomes, is that it's a very common cause of miscarriages. Many embryos that are affected with Turner syndrome do not make it to birth. They miscarry during the first trimester and sometimes a bit later. So this takes us to why we should perhaps think about performing PGS. And I can already tell you that we perform PGS not so much to reduce the birth of Edwards syndrome, Down syndrome, Pateau syndrome, Turner syndrome, but rather we do this because these chromosomal abnormalities are so common in miscarriages. We do this mostly to improve the chances that the pregnancy will be successful. So if we look at this graph, it tells you what is the likelihood of a patient to conceive, the green line, according to her age, which is the bottom line. And you can see here very clearly that there is a drop in the fertility rates in women. The drop is pretty steady up to about somewhere in the mid-30s. And then from the mid-30s onwards, the drop in the fertility speeds up quite considerably. In parallel to this drop in fertility, you can see an increase in the risk of miscarriages, and you can see how steeper this curve becomes from the mid-30s onwards. So clearly, something happens to women's eggs, which makes it a lot more difficult for them to conceive. And if they conceive, it makes it a lot more difficult for them to actually have a successful pregnancy. This graph shows you what is the likelihood that the pregnancy that women conceive, when women conceive, how likely is that the pregnancy will have trisomies, any trisomy. It can be trisomy 21, 18, 13, 6, 13, a whole host of difficulties that can happen with the makeup of the chromosomes. And you can see how age-related that is. It's the figures here are probably a bit small and difficult to be seen, but you can clearly notice that from the mid-30s onwards, there is a steep increase in the occurrence of trisomies, in the occurrence of chromosomal aberrations. More than 25% of clinically recognized pregnancies, not births, any pregnancy, pregnancies that miscarry, pregnancies that carry on, but then you do a test during pregnancy and to find out if there is an abnormality, and pregnancies that make it to term and the baby is delivered. More than 25% of the whole cohort of these pregnancies have got aneuploidies, have got an abnormal makeup of chromosomes. This graph shows you specific prevalences, specific occurrences of trisomy 21, which is the red line, trisomy 18, which is the green line, and trisomy 16 according to ages. And the graph is very clear. There is a sharp increase in the occurrence of these trisomies as women age. Now, I'll talk to you about these three graphs. They show you again the risk of having aneuploidies, having an abnormal makeup of chromosomes. Firstly, that you will be diagnosed with such abnormalities while you're pregnant. So these are more or less successful pregnancies. They go to about 10 to 20 weeks. And these women have an amniocentesis test in which they take some cells from the fluid around the baby, or chorionic villus sampling, CVS, which we do at about 10 weeks gestation, and we remove a few cells from the placenta, and then we analyze the chromosomes of the baby. At the age of 30 to 31, about 0.2% of pregnancies will be found to have an abnormality, while at the age of 43, you will have about 3%. So this is a more than a tenfold increase in the diagnosis of abnormalities in utero. This graph shows you what is the risk of miscarriages as women age. At the age of about 30 to 31, 10%, doubles at the age of about 38. But look at this, at the age of 43, 44, 45, you're looking at a good 60, 65% of pregnancies ending up with a miscarriage. And this blue graph shows you how likely is it that the embryos you produce in IVF treatment will have a chromosomal abnormality. And these embryos that have a chromosomal abnormality will either not implant to begin with, or if they implant, they will end up with a miscarriage. So at the age of 30 to 31, surprisingly, a high proportion, relatively, have chromosomal abnormalities. About 30% still have chromosomal abnormalities. But look at those figures. At the age of 40 to 41, 65% will have an abnormality. And at the age of 44 to 45, 85% will have an abnormality. So these figures clearly show you why there is such a pronounced age-related drop in the success rate of IVF. Why is it that at the age of 44 to 45, every single IVF treatment cycle you offer to patients gives them more or less a % chance of having a baby? And why is it that at the age of 40 to 41, every given IVF treatment cycle is associated with a 10 to 12% chance of getting pregnant only? Now, what is the issue? The issue is that when you look under the microscope and you grade the embryos and you decide which embryo you should put back inside, the look of the embryo can be quite deceiving. You can look at the embryo and say that this embryo looks actually very nice. It will be a perfect, let's say, day 5 embryo, a blastocyst, and it will still have significant chromosomal abnormalities. This means that often the choices to which embryos we transfer and which embryos we freeze is not the right one. So look, let's take a woman who is 41-year-old and she is lucky and she has 6 day 5 embryos. She has 6 blastocysts, and we put them under the microscope and we see that one of these blastocysts looks perfect. And we see that some other blastocysts don't look perfect. They look blastocysts, but they are not top-grade blastocysts. We put the top-grade blastocysts back, we freeze the others, And we think that we made the right choice. But very often, she does not get pregnant with the first embryo that we transferred, the top grade embryo, or she gets pregnant with it, and then she miscarries, and we check the products of conception, and we find that this embryo had a significant chromosomal abnormality. And then she comes back and she uses the lesser qualities embryos, and she gets pregnant and she delivers a healthy baby. So the correlation between how well the embryo looks under the microscope and how well it is from the point of view of its complement of chromosomes, this correlation is not very good. And that's, this slide tells you the same thing in other words. So what happens as a result of that? What happens as a result of our imperfect embryo selection process when we base it solely on morphological grading, solely on how well does the embryo looks under the microscope? What happens is that we prolong the patient's fertility journey. As they fail to conceive or they miscarry after having the good-looking embryo transferred, and they only manage to conceive with the frozen thawed embryo replacement after the failed cycle, and with the embryos that did not look as nice, but happens to have the normal makeup of chromosomes. This is this is not the worst case scenario. The worst case scenario is that at times the entire cohort of embryos that this patient have significant chromosomal abnormalities. So go back to this 41-year-old lady who has 6 embryos, 6 reasonably good-looking embryos. And we put 1 or 2 back, and then we freeze the rest. And none of these embryos have a normal makeup of chromosomes. So what we are subjecting her to is having the embryos put back 1 by 1 or 2 by 2, spending 6 months or maybe a year trying to conceive with these embryos, either having failed implantation or worse, having the embryos implant but end up with a miscarriage. And we have wasted a year of her time at the age of 41, when her time is really, really very precious. So this is not only disheartening, her journey is not only disheartening, but it is also possibly not an efficient way you could use her time. So being aware, and there's another aspect to it, another advantage that PGS may have, because we are aware of the risk that good-looking embryos could be, in fact, genetically flawed. They may have an abnormal makeup of chromosomes. It is common practice for us to transfer 2 and sometimes even more than 2 embryos in older women. So the thought there is, let's put 2 or 3 embryos so that we increase the chances that at least one of them carries the right makeup of chromosomes and will lead to a successful pregnancy. The problem with this approach is that every now and then, the 2 embryos we put back actually both have a normal makeup of chromosomes, and then you end up with twin pregnancies. And twin pregnancies, and sometimes even triplet pregnancies, are beautiful. They're hard work, but they're beautiful, and they're good as long as everything goes well. The issue with twin pregnancies, and needless to say with triplets, is that the pregnancies are high-risk pregnancies. Anything that can go wrong in pregnancy is a lot more likely to go wrong if you have twins or you have triplets, obviously. And therefore, ideally, we wish to be able to put your embryos back inside your womb 1 by 1, so we do not subject you to the risks of twin pregnancy or triplets. Our aim is not that you get pregnant. Our aim is that you have a healthy baby at the end of the day. And if we put 2 embryos back and you have twins, and then you, God forbid, you have an early labor at 26 weeks, and your babies go into intensive care, and they go through weeks of intensive care, and they may have severe handicap, we did not do good service for you. So the advantage that PGS can have from that point of view is that you can make sure that the embryo you put back has got a normal makeup of chromosomes, and therefore it is a lot more likely to implant, and you can put it back by itself without another sibling embryo and reduce the risk of twin pregnancies. So if I needed to summarize the possible advantages of PGS, then firstly, you improve the pregnancy rate. You improve the pregnancy rate as long as you end up with a normal embryo. That you find that it's from the cohort of embryos that you have at least one good embryo to put back. Once you have a euploid embryo, once you have an embryo with a normal makeup of chromosomes, and you put it back, you can expect a pregnancy rate that is similar to that of a woman who is under the age of 35, regardless of her actual age. So if you are lucky and you have a 43-year-old lady who comes to you, produces a good number of blastocysts, you test the blastocysts, you find out that she has one normal embryo, you put it back, she has now a pregnancy chance of at least 50%. If you didn't do that and you put the embryos without testing them, her chance would probably be about 3 to 5%. Now, the other thing that you may be doing by testing the embryos, testing whether they have a normal complement of chromosomes or not, is to decrease the miscarriage rate. As I showed you earlier, the chromosomal aberrations are a very common cause of miscarriages. You can increase the multiple pregnancy rate, you can increase the risk of twins and triplets, as I discussed with you earlier, because once you are certain that the embryo has got a normal makeup of chromosomes, you're very often tempted to put only one embryo back or do what we call a single embryo transfer. You decrease the time to pregnancy, as we discussed earlier. You shorten the fertility journey by doing this. And you may also offer the patient a treatment plan which is more cost effective because you don't spend money doing unnecessary embryo transfers with embryo that you could say from the outset have no chance of ending up with a successful pregnancy. So if you looked at all the possible advantages here, who would be a good candidate for PGS IVF treatment with PGS? So surely you would offer it to women with advanced maternal age, women who are more likely to have abnormal embryos, and it is therefore more useful for you to know which embryos are normal and which embryos are abnormal. If at the age of 30 to 31, only a third of your embryos are abnormal, you can probably take the risk and put them back without testing them, because there is a good 2 to 3 chance that the embryos you're putting back have got a normal makeup of chromosomes. But if you are putting the embryos back at the age of 43, 44, there is an 85% chance that the embryos are abnormal, and it is a lot more likely that the embryos you're putting back, if you're not going to test them, have got an abnormality and will end up with a failed implantation or with a miscarriage. You could use this in women who have multiple implantation failures. Again, the issue here is not so much to improve their chances or to maybe be a bit more cost effective, but rather you're looking now at certain battle fatigue. This couple or this woman had treatment had failed embryo transfers, you want to now be able to offer her treatment that ticked another box. You know that the embryos you're putting back have normal makeup of chromosomes. You know that at least you're not subjecting her to failure as a result of an abnormal makeup of chromosomes. Certainly, that is even more the case, the psychological, emotional aspect is even more the case when you are when you see a patient in your clinic who had some sort of a disheartening fertility or pregnancy history. These are women who needed to perhaps terminate a pregnancy because the baby was diagnosed with some sort of a chromosomal abnormality, or had a late miscarriage or even early labor as a result of the baby carrying a chromosomal abnormality, or had a baby who was delivered and was affected by a chromosomal abnormality. And some of these babies are absolutely fine. Down syndrome babies have got a good quality of life, but other chromosomal abnormalities, actually the first few weeks or months of the life of the baby is an experience for the patient, for the couple or for the parents, which is a very difficult experience. You want to do this again for the same reason for women who had recurrent miscarriages, and there's also a relative indication to suggest that you may want to do this in couples who have severe male factor subfertility, because it is suggested that men who have a very low sperm count could subject their pregnancies to a higher risk of miscarriages and perhaps also a risk of chromosomal abnormalities. In good prognosis patients, you will do PGS to be able to transfer only one embryo, embryo that you know has got a normal makeup of chromosomes, refrain from doing double embryo transfers or triple embryo transfers and ending up with twins or triplets and an increased risk. So far we discussed about the possible advantages and possible indications. But what is theoretically right very often does not stand the test of reality and is not perhaps clinically right. And I will talk to you about some of the evidence or some of the concerns that have been flagged up as to the use of PGS. And so that you're able to understand the concerns, I will talk to you about the practicalities of PGS. How is PGS carried out? We will ignore the top slides and we'll talk about the two main pathways or two main stages in which PGS can be done. So what you see here in this middle photo is a biopsy carried out on a day 3 embryos. If you recall my slides from previously, this is the shell of the embryo, and these are the cells that the embryo formed when it divided from a fertilized egg to 2 cells, 4 cells, 6 cells, 8 cells. This is an 8-cell stage embryo. There are about 8 cells in that shell. This is the image that was taken under the microscope, very similar to what you saw with the ICSI procedure. There is a suction pipette here which holds the embryo in place so it does not move. The embryologist had already made a hole in the shell of the embryo using a laser gun normally nowadays, and then introduced a suction pipette into the embryo to suck, to aspirate one of the cells to be removed from the embryo. This cell is then tubed and sent to a genetic lab where the chromosomes of these cells are analyzed, and we get a verdict about whether it is normal or whether it carries an abnormal makeup of chromosomes. In the old days, when we used to do this, when we used to do a day 3 biopsy, we would process the sample in the genetic lab very quickly and get an answer as to whether it is normal or abnormal in 2 days. By that stage, when the embryo was already day 5, we will have expected it to become a blastocyst, and we would have been then able to transfer it if it was normal. The issue with this technology was that when we looked at the results, we found out that this is probably to a degree harmful to the embryos. Because what you do here essentially is remove an 1/8 of the embryo away. You remove 1 out of 8 cells away. And you could hamper its chances of developing further into a blastocyst stage and its chances to implant. The other thing we found out was that we had a very high rate of mosaicism, and I will explain to you what I'm referring to. It is very possible that when you do a biopsy on day 3 and you remove 1 cell, this cell happens to be abnormal, but actually the cells next to it are mostly normal. And then you make a verdict on the whole embryo on the basis of the single cell you sampled, and this verdict is not just. So you end up discarding embryos on the basis of 1 cell sampled, and you're discarding normal embryos. When a study has been done to see whether the implementation of day 3 biopsy for the purpose of PGS improved the chances of successful pregnancy in women, the results showed that it was the case that it not only that it did not improve the chances, it in fact hampered the chances of conception. So this method has been pretty much abandoned. What we do nowadays is we culture the embryos to a blastocyst stage. We wait for them to become blastocysts. And what we do then is a blastocyst biopsy. So this is the blastocyst. You can see it here in higher magnification. And what we do in a blastocyst biopsy is remove a few cells from the cobblestone appearance of the embryo, the layer of the cells that will become the placenta and the membranes, not the inner cell mass, not the part of the embryo that will become the actual embryo, but rather what will become the placenta and membranes. We will remove 5, 6 cells, or that number of cells, and we will send them then to the lab to test them and see whether they contain a normal makeup of chromosomes. Once we did that, we will freeze the embryos and we will wait for the results. Once we get the results, in a subsequent cycle, we will thaw the embryos that are normal, or an embryo that is normal, and we will put it back. You will see the biopsy process in the next slide, which we will upload now, and you will see how it happens in reality. Here you see the blastocyst under magnification. The embryologist has already slit a hole in the shell of the embryo, and it's now sucking with a suction pipette a few cells into this pipette, into this biopsy pipette. You think that nothing is happening, but in fact, they are using a bit of tension, very gentle tension, to be able to remove those cells. To slit the hole in the shell, they use a laser gun, and very often just sucking the embryos to be able to, sucking the cells to be able to detach them from the embryo is not enough, and they need to use laser gun here too to just separate the cells from the rest of the embryos so you can tube them and send them to the genetic lab for the purpose of chromosomal analysis. This is a real-time clip, so you will see how it is done In reality, it takes a bit of time, but you will soon see the cells coming away from the embryo, getting detached and removed for the purpose of analysis, of chromosomal analysis. Here we go. They are detached. You will soon see the clump of cells there in the pipette. This will be removed, put in a tube, sent to the embryology lab. I think that this is understood. We can stop the video here and move on. So what happens in the embryology lab? In the embryology lab, they need to amplify the genetic material from these cells. You can't do an analysis on 4 to 5 cells. You need to get the DNA, the genetic material from those cells, and amplify them in the lab by a technique called PCR. It doesn't matter. And then once you have a decent amount of genetic material, you then run the genetic analysis on those on this material, and you can use a couple of genetic technologies, CGH or NGS. It doesn't matter. The more modern way of doing this is NGS. The technology is not really very relevant for our talk. Now, you looked at the biopsy, and I think that you could already say that that is perhaps not the most healthy thing you can do to an embryo, and I will come back to it soon. But before we talk about it, I will tell you already that there could be lots of advantages to PGS, and there could be certain indications in which PGF certainly has got a role, but our regulatory body, the HFEA, has classified PGS as an add-on. And the definition of add-on is not necessarily the best term to be used, but nevertheless, the definition of add-on is an emerging technique or technology that may have shown some promising results in initial studies, or may have been around for a number of years, but has not necessarily been proven to improve pregnancy or birth rates. So the message here is that the jury is still out. We cannot say with 100% confidence that the application of PGS in IVF treatment is definitely advantageous. And furthermore, we cannot say in which indications there has been a proof that it is certainly advantageous. The HFEA uses a traffic light system to describe the strength of the evidence to support the use of add-ons. So there are certain add-ons, not PGS, that have been given a red light, and there the verdict is that, according at least to the HFEA view, the add-ons are of no known benefit. So when it comes to PGS, the biopsy on day 3 has been given a red light, which means that there is no evidence to say that this add-on is effective. And a biopsy on day 5 has been given an amber sign to say that there is conflicting body of evidence for this add-on and further research is required. I think that it's not so much that there is a conflicting body of evidence. It is more to say that there is not enough evidence, that the body of evidence is perhaps not strong enough to say that it definitely works. It is very important for you to remember that PGS will not increase your overall chances of having a baby. So if I go back to this 41-year-old lady who has treatment and forms 6 blastocysts, if one of the 6 blastocysts she formed has got a normal complement of chromosomes, this blastocyst will implant and perhaps end up with a successful pregnancy, whether you diagnose it to be normal or you do not diagnose it to be normal with the use of PGS. The question is, how long will it get you and the couple or the patient to get to a point where when you transfer this embryo, because very often the embryo with the normal makeup of chromosomes will be the last you transfer. So this patient will go through 1, 2, 3rd embryo transfers until she is successful. But she will get pregnant whether you did the PGS or not, because the PGS will not improve the makeup of the chromosomes. It will only tell you if the embryo is normal or not. So it cannot increase your overall chances. So in essence, and this is a very important message, and if you want to remember anything from this presentation, please take this message with you. PGS is essentially an embryo selection tool. And you should perhaps restrict its use to when you have a cohort of embryos to select from. In other words, I'm not sure to what extent it has a role in women who form 1 or 2 blastocysts, when you can simply put those blastocysts back and not perhaps inflict any damage on them by performing a biopsy. I have to say, though, that it is my practice to offer this to patients who have only 1 to 2 embryos, not as an embryo selection tool, but rather as a tool to reduce the impact of unsuccessful pregnancy on their emotional or psychological well-being. And I do this in couples or patients who had a disheartening fertility history or a disheartening history of failed pregnancies. In which case, it is important for me and important for the couple or the patient to make sure that this box is ticked, that at least we know that the embryo we put back is normal. It will not guarantee a successful pregnancy, but it will reduce the risk of ending up with another disheartening event, with another miscarriage, with another preterm labor, with another diagnosis of a chromosomal abnormality with an amniote synthesis or CVS while they are pregnant, and a need to have a termination of pregnancy. What are the concerns with PGS? What are the 2 main concerns? So as I alluded to, one of the main concerns is the possibility, we don't know that, but we need to assume that there is a degree of risk, a possibility that the biopsy itself, the procedure, may cause a damage to the embryos and therefore will reduce the overall chances of conception. So you may end up hampering the chances of an embryo to implant, although it has a normal complement of chromosomes, only because you removed a few cells from the layer of the cells that will become the placenta and the membranes. We cannot quantify the risk. I cannot tell you how pronounced the risk is and how negligible the risk is. I can only tell you that the implantation rate after PGS, once you have a normal embryo and you put it back, the implantation rate is actually rather good. So I can say that if there is a risk, the risk is probably not huge. But I can also tell you that at least in the number of patients I followed and in patients who had treatment elsewhere and the clinicians shared their experiences with me, we found that there were still patients who miscarried after having implantation of an embryo that had PGS, that we knew that had no abnormal makeup of chromosomes. And we always question ourselves whether the miscarriage was not a result of the biopsy. And we can say with confidence that the miscarriage happened because of something to do with the ability of the patient to carry the pregnancy to term and we do not know. We simply do not know. The other concern there is that there is a possibility, even with a biopsy carried out on blastocysts on day 5. I told you about this with biopsies carried out on day 3, but it could be that to a lesser extent, this concern is also valid when you do biopsies on day 5. There is a possibility that the cells that you sample do not reflect the makeup of the chromosomes of the entire embryo. So you end up sampling a local area of abnormality when the rest of the embryo is actually absolutely normal. And then you end up discarding embryos, which could have led to a successful pregnancy. These are the two main concerns when it comes to the use of PGS in IVF practice. If you opt for PGS, you will need to be ready for the following possible unfavorable outcomes. It's not always a case of you did PGS and you were told, okay, you had 6 embryos, one of these embryos is normal, we are going to now transfer this embryo. Because it's a normal embryo, you have a 50-60% chance of implantation, which is phenomenal because you're 41, and without the PGS, from the outset, you would have only gotten 10 to 12%. Very often, we do the biopsy on 6, 8, 10 embryos, we wait for the results, and we find out that the entire cohort of embryos was abnormal. So this patient had stimulation, she had a biopsy, she waited for a few weeks for the results of the biopsy, only to be told that there are no embryos that are suitable for transfer. So it can happen when you do PGS, you need to be ready for it. You could argue that in fact this scenario is disappointing, but perhaps not disheartening, because that saved the couple or the patient from unnecessary embryo transfers, or even possibly from a miscarriage. Another possibility is that you are told that the genetic material that we send to the genetic lab, the few cells that we biopsied and sent to the genetic lab and needed their genetic material to be amplified, this genetic material was not of good quality for this or the other reason, and the amplification of the genetic material failed. Once the amplification of the genetic material fails, you cannot have the chromosomal analysis. It's just not possible. So what you end up with there is being told, listen, we don't know if your embryo is normal or abnormal. The test simply failed. You can still transfer embryos that had a biopsy and had a failed amplification of the genetic material. You just don't know whether they are normal or not. So the transfer is exactly the same as you could have done without the biopsy. If you opt for PGS, you also need to be ready for the possibility that the result of the genetic tests are not normal or abnormal, but rather they are mosaic. So what they tell you there is you had 6 cells in that biopsy, and we think that 4 of the 6 cells were normal and 2 of the 6 cells are abnormal. It can happen. And the interpretation of such results is actually very difficult. It's very difficult to tell you whether you should transfer these embryos or you should refrain from transferring those embryos. Under certain circumstances, when all the other embryos are abnormal and the only thing we have is a mosaic embryo, we do transfer such embryos. And there are reports of normal pregnancies and babies that are delivered and they appear to be normal too. The majority of such embryos will not implant or miscarry. But we cannot rule out a risk that such embryo will implant, will not miscarry, and will end up with delivery of a baby who may be affected by a serious disability. So this is another outcome of PGS which you should be aware of, and you should understand the dilemmas there, and you should understand that sometimes the verdict we give you is not a black and white verdict. I'd like to end here and give you a bit of time to ask questions. I wish to thank the people who appear on this slide for their help with this presentation, and also thank my entire team here at GENNET City Fertility who support me in this sort of activities.
And thank you, Dr. Abramov, for your great presentation and making the explanation for all those complicated matters so accessible and so easy to understand. I have actually confirmation of my words also, which I can present to you. Great webinar. Thank you, Doctor. You have explained this complex topic in clear way. It is very helpful information. Thank you a lot. And yes, as you just said, we will now have time for Q&A session. So if anybody has any question, please type those questions in the chat section. The time is actually now to do that. And we will take the first question as we have a few. And the first question will be this one. My husband has balanced translocation. We did PGS and transferred the normal embryo, but twice it failed. First time it didn't implant, and second time there was no heartbeat. Was there something wrong in PGS result? Is there any chance to get normal embryo in our case?
Okay, this is actually a question. First of all, I have to say that I'm really sorry to hear that and to read this, because this is really disheartening. You normally have high expectations when you transfer a normal embryo. But I'm thankful to your question, because I think that it is important to emphasize the distinction between PGS and PGD. What you went through is not really PGS, although the technology is the same. The way that the embryos were dealt with, the biopsy, even the analysis is the exact same thing. What you had was pre-implantation genetic diagnosis. I would call it pre-implantation genetic diagnosis because you have a known issue. You have a known genetic issue. The known genetic issue is the fact that your husband is a carrier of a balanced translocation. Having a balanced chromosomal translocation doesn't affect you, because you still have a normal copy of all the genes that you need. The issue with having balanced chromosomal translocation is that the embryos that you produce will be a mix of normal embryos and abnormal embryos. But the vast majority of the embryos that you produce will be abnormal, regardless of female age. And because the vast majority of the embryos you produce once you have balanced translocation are abnormal, you are a lot more prone to failure of implantation and a lot more prone to miscarriages. So this is a different story. There is no, in my opinion, there is no doubt that in your case, the biopsy and the chromosomal analysis on your embryos is essential, because without it, you subject yourself to a risk of miscarriages. You subject yourself to a long period of time before you happen to have a normal embryo implant naturally. Now, why your embryos did not implant, and why when it implanted, it did not go any longer than a certain stage and you had no heartbeat, that is a very difficult question to answer. Is it related to the fact that you had a biopsy on those embryos? Perhaps. As I said, there is a degree of concern as to what does the biopsy cause to the embryos. At the end of the day, you remove a few cells from the layer of cells that needs to become the placenta and membranes. So you could perhaps hamper the implantation process and the formation of the placenta and so forth. But it is important, in your case, to look at other possible causes that have got nothing to do with your embryos, which have got perhaps to do with what is happening with you. Do you have any uterine malformations? Do you have any circulating antibodies that cause an antiphospholipid syndrome? Do you have any issues with your clotting system, etc., etc.? And this is something that your fertility experts, the doctors who take care of you, should do for you. I hope that it answered your question.
Thank you a lot for your answer and for the question as well. It was very informative, so we will then take the next question. And this question is this one. Is PGS always safe with blastocyst, or must an embryologist be very experienced to perform this procedure?
Again, a brilliant question. Thank you for that. You need to have your biopsy by an experienced practitioner. There is a recent study that showed that there is a significant difference in the outcome according to the experience of the practitioner. If the practitioner is really skillful, the practitioner will remove just about what you need for the sake of the chromosomal analysis, 4, 5, 6 cells. If the practitioner is not that experienced, he or she will remove 10 cells or so, and that will have a much more pronounced effect on the health of your embryos. If you veer to the other extreme and you remove fewer cells than what you need, you have failure of amplification of the genetic material, and you have inconclusive results. So the answer to your question is you certainly need to have your biopsy carried out in a center that has good practitioners.
Thank you for the answer and for the question, of course. We will then jump to the next one. Good evening from Norway. Thank you so much for giving us this opportunity to assist this brilliant presentation. My question is PGT, but of PGS, which we know from the follow-up comment, is PGS indicated for IVF with egg donation, especially the donor age is less than 30 years?
So this is actually really a good question, because it illustrates the dilemmas in our field. If your donor is younger than 30 years of age, chances are that the vast majority of the embryos she produces are chromosomally normal. If you remember the data on my slides, at the age of 31, 32, the rate of abnormalities is estimated to be at around 30%. So there is a good 2 to 3 chance that the embryos you are transferring are actually chromosomally abnormal. So you need to balance here the odds with the possibility that the biopsy will do more harm than good. And the question there is, how many embryos do you have? And how many attempts have you had, and so forth. So if this is the first embryo transfer, and if you have 4 blastocysts, my inclination would be 3-4 blastocysts. My inclination would be just put the blastocysts back. Do not inflict any possible damage on them by doing a biopsy. And you will have a good chance that what you're putting back is actually chromosomally, genetically normal. But if you have had 2 failed cycles with the same donor, and you have another 6 to 8 blastocysts in storage, then you're starting to think, how long am I going to do this? How many more embryo transfers am I going to do before I get an understanding of whether the failures I have experienced are to do with an abnormal makeup of chromosomes or due to a different story? So I think that the answer to your question is, it really depends on your circumstances. I hope that it answered your question clearly, but if it didn't, I'll be happy to elaborate.
Thank you for your explanation. A huge thank you for the question as well. Then we will take the next question, which is actually, yes, we have question in 2 parts. So we have transferred NGS tested normal embryo. However, it resulted as biochemical pregnancy. The explanation from our doctor was that embryo didn't have enough energy. Well, do you think that it's embryo related? And the second part is, by the way, prior to the transfer, we have done ERA, uterus biopsy for NK cells, and hysteroscopy just to ensure that our embryo will implant.
Thank you. Biochemical pregnancies are a difficult issue in our field. I have to be honest and tell you that we don't completely understand why biochemical pregnancies happen. I think that what your practitioner alluded to when he or she said that the embryo did not have enough energy was along the lines of the analysis of the mitochondria in the embryos or in eggs. Mitochondria are little bodies, little organelles, little structures that are found in any cell in our body. And they are the power plants of the cell. They produce the energy that the cell needs to maintain its processes, to maintain its infrastructure. There is an observation that shows that eggs of older women have got fewer mitochondria. So there is an issue with the mitochondria in older women, in the eggs of older women. And there is a theory that suggests that embryos can implant or fail to implant not only because they have a normal makeup of chromosomes or they have an abnormal makeup of chromosomes. You can test that when you do PGS. You can actually test for this too. The issue there is that if you think about IVF, you can think about it as having your embryos put through a sieve, through a filter. The first sieve, the first filter, is the morphology or the development in the lab. You have embryos that make it to day 3 and fail to make it to day 5. So that's the first sieve. And then you have a number of day 5 embryos, blastocysts. And then you can do a biopsy on them and see whether they have a normal makeup of chromosomes or they don't. And as you could have learned from in between the lines of my talk, you got to be lucky to be able to have 1 or 2 or 3 normal embryos, embryos with a normal makeup of chromosomes that you can transfer. Now, if you add another sieve, then you can even have fewer embryos that are suitable for transfer. So I am not sure to what extent the mitochondrial analysis of the embryos is a useful clinical tool. That's the answer to my question. But it could be that the embryo that you put back did not implant because of that issue. It could be that it did not go beyond implantation because of the fact that it had a biopsy. It could be to do with other factors completely. It will be very difficult. We need to be honest. It will be very difficult to point a finger on a single factor and tell you that this is what might have caused it.
And huge thank you for this explanation and detailed answer as well. We have actually additional comment to that, so I will display that as well. And now we have done another cycle before moving to donor eggs. We have 6 day 3 embryos frozen from the cycle. We will make them to proceed to day 5 and then transfer as a blast without NGS this time. If you want to add anything.
I think that it's probably a sensible decision. If you have 6 day 3 embryos, you need to see how it pans out. You need to see how it develops. It's normally the case, although sometimes we are really lucky and the outcome is really good, but it's normally the case that not all these 3 embryos become blastocysts. So you may end up with fewer than 6 blastocysts. And if you have 2, 3 blastocysts, it is possibly the case that the better way of going about is just to transfer them.
And thank you for adding this to the answer. Dear all, this will be also the final call for the questions. So if anybody wants to ask any questions more, please do that. We have for now one question more, so we will take this one. Sorry to go back again to my question regarding the balanced translocation. Is our only hope to use donor sperm then?
No, absolutely not. The odds are that the vast majority of your embryos carry an abnormality, but you still make normal embryos. The ratio between the normal embryos and the abnormal embryos is unfavorable, but you do still have a chance of ending up with a normal embryo. So it is really a question of resilience. I don't know where you're having your treatment, but here in the UK, a lot of what we do is self-funded. So there's the issue of financial resources. There's obviously the issue of emotional resources. This is emotionally taxing. It's difficult to go through treatment. It's difficult to go through the phase that you wait for the biopsy results, and then you put an embryo back and you wait for the result of the pregnancy test, and then you wait for the scan to see if there's fetal heartbeat. The process is emotionally taxing. So it's only a question of how resilient you are, financially, psychologically, emotionally. But you do still have a chance of having a normal embryo found in this process, and you do have a chance that this normal embryo will implant and end up with a healthy baby. I can tell you from my experience, I have treated lots and lots of patients with balanced chromosomal translocation. In many of them, we were successful. It's a question of how many times you're happy to try this.
And thank you again for the answer, for all the knowledge and support you gave us this evening, Dr. Abramov. For now, I cannot see any questions, so we will be then slowly finishing. And this was a great pleasure to have you here today, this evening. And of course, a huge thank you to Dr. Abramov for the presentation and a huge dose of knowledge which we have been given this evening. I have huge thank you for all of you and for you, of course, Dr. Abramov, and for GENNET City Fertility that you did this webinar with us. If you want to add anything, please do that.
Just wanted to thank you for hosting me and to thank all our listeners who I gather some of them are from far away. Thank you for taking the time to listen to me.
Yes, exactly. Thank you for your time. Thank you for being here with us today. And of course, please stay in touch with us. Follow us on our social media. Subscribe to our YouTube channel, where you can also find all the recordings from IVF webinars so far. And of course, this one with Dr. Abramov as well. It will be available on our website tomorrow, and it will be a great pleasure to have you all here on our upcoming IVF webinars. We are here every week on Tuesdays, so feel free to join us. And yes, it will be a wrap. Thank you one more time. Thank you for the knowledge. Thank you for your time. Have a great day, great evening, wherever you are, and see you back here soon. Bye.